Welcome to the deep dive. Today we're taking a serious look at an organ that is, well, an absolute powerhouse of digestion and absorption, yet it often goes quietly about its business
Ah,
until something demands our attention. We're talking about the small intestine.
it truly is remarkable. I mean, a structure of incredible complexity, performing the vast majority of nutrient and fluid uptake.
Mhm.
But as you said, its conditions can be, well, notoriously challenging to diagnose and manage.
Exactly. And for this deep dive, our goal is to use the source material you've shared, primarily excerpts from what looks like a foundational surgical text, to build a truly solid understanding of this vital organ.
Mhm.
Think of this as your shortcut, maybe a way to unpack these pages and grasp the material deeply, almost like you're aiming for mastery, like the elite professionals in this field do when they approach this subject.
Right.
We're going to pull out the most important insights, connect the anatomical structure to its physiological function, and then explore the range of conditions that can affect it, drawing directly from the text.
Okay. We'll start with the fundamentals,
Hmm.
the anatomy and the, well, incredible functional capacity. Then we'll shift to common problems, the inflammatory and infectious processes, the rare but significant tumors,
Right?
the structural issues that can disrupt function and lead to malabsorption, and the devastating impact of vascular problems or severe intestinal failure.
Wow.
And finally, we'll touch on surgical interventions like stomas, which are, often necessary in managing these conditions.
It's a lot to cover, but that's the point of a deep dive, isn't it? Let's get started by laying the groundwork, the foundational anatomy and physiology of the small intestine.
Okay, let's unpack this. So when we talk about the small intestine, especially from a surgical viewpoint, as this text does, we distinguish the very first part, the duodenum, which, usually gets its own dedicated discussion.
Right, separate topic.
Exactly, from the rest. So the bulk of the small intestine extends from a specific landmark called the duodenojejunal flexure, often shortened to the DJ flexure,
PJ flexure, got it.
all the way down to the ileocecal valve, where it meets the large intestine.
And right away, one striking feature is its length. The source points out a surprising amount of variation, anywhere from, 300 to 850 centimeters? That's a huge range.
It really is. It even notes that some studies suggest it's longer in men. Though, pinning down an exact measurement can be tricky, whether you're doing it during surgery or after death or even on imaging.
So that variability is a key point. It's not a fixed length at all.
Not at all. Despite this range, it's conventionally divided into two main segments. The jejunum, which makes up the proximal roughly 40%, and the ileum, the remaining 60%.
But it's not like a sharp cutoff, is it? More of a gradual change.
Exactly, it's a transition zone.
Right.
But there are distinct differences that are important clinically. The jejunum typically has a wider diameter and a thicker wall. Its mucosal lining has more prominent circular folds, known as valvulae conniventes.
Ah, yes, those folds. They're like internal ripples, aren't they? And their main job is to increase the surface area, I guess.
Precisely. They dramatically increase the surface area available for absorption, and they also sort of slow the passage of intestinal contents,
Right, gives it more time.
allowing more time for that absorption to occur.
Yeah.
The ileum, by contrast, tends to have a thicker, fattier mesentery. That's the supporting tissue holding the bowel to the back abdominal wall.
Okay.
Within that mesentery, the network of arterial blood vessels, the arcades, it's more complex. The ileum is also home to larger aggregates of lymphoid tissue called Peyer's patches.
And I remember learning those Peyer's patches can be clinically significant later on, sometimes even acting as like a lead point for intussusception, where
Yeah.
the bowel telescopes.
Yes, exactly. Especially in children.
Hmm.
That's a classic scenario where their location becomes really relevant.
Yeah.
Now, understanding the supply lines is absolutely fundamental. The small intestine receives its blood primarily from the superior mesenteric artery, the SMA.
The main highway, yeah. Straight off the aorta.
It is. And the venous drainage mirrors this arterial supply, with the superior mesenteric vein joining the splenic vein to form the portal vein.
Okay, the portal vein.
And this portal vein carries all the blood draining from the small intestine directly to the liver. This is a crucial step because it means all the absorbed nutrients, and potentially harmful substances too, are processed and detoxified by the liver before entering the main systemic circulation.
Mm-hmm. Right.
The liver acts as this critical filter and processing center for basically everything absorbed from the gut.
So the liver gets first pass at everything we absorb. That's huge.
A critical first pass, yeah.
Yeah.
The nerve supply is also dense, derived from the autonomic nervous system via the sklanchnic nerves, contributing sympathetic fibers that kind of wrap around the SMA branches. This rich innervation helps explain the location of pain originating from the small intestine.
Like that classic periumbilical pain. Is that because of the nerve roots where they come from?
Exactly. The sensory nerves from the small intestine trace back to the T10 spinal cord level, and the area of skin supplied by those T10 nerves, the T10 dermatome, is located right around the umbilicus, the belly button.
Ah, cool.
So pain from the small bowel is often referred to that central umbilical region. Understanding this neural mapping is really key to interpreting symptoms.
Makes sense.
And the lymphatic drainage, which is vital for transporting absorbed fats and immune cells, also follows the path of the arterial supply within that mesentery.
So when a surgeon operates on the small bowel, the mesentery isn't just, an attachment point. It's like a roadmap to all the vital vessels, nerves, and lymphatics.
Absolutely. It contains all that critical infrastructure that needs to be handled really carefully.
Yeah.
Okay, now let's talk about the powerhouse function. The small intestine's principal role is the digestion and absorption of virtually everything we eat and drink.
This is really where the body extracts what it needs from our food, isn't it?
It is. The breakdown of carbohydrates and proteins, it starts in the lumen with pancreatic enzymes, but the final step, the hydrolysis into absorbable units, that happens right at the brush border, the very surface of the intestinal lining, particularly in the jejunum. Fats are digested by pancreatic lipase, aided by bile salts from the liver and gallbladder. The digested fat products, fatty acids, and monoglycerides, then separate from the bile salts and get absorbed, mainly in the jejunum too.
Is different stuff absorbed in different parts, or is it just kind of all happening everywhere?
No, there's a really important regional specialization. While the jejunum is the primary site for the bulk of absorption fluids, electrolytes, iron, folate, most fats, proteins, carbohydrates. The terminal ileum, that last section, is unique.
Unique how?
It contains specific transport systems found nowhere else in the small intestine, dedicated solely to absorbing bile salts and vitamin B12.
Wow, okay, so only the terminal ileum can do that. That sounds critically important for what happens if a section is removed then.
It is. The consequences of resection depend heavily on which segment is lost. If you resect a significant length of jejunum, the remaining ileum often has this remarkable capacity to adapt and take over many of the jejunum's functions.
It can compensate.
It often can, yeah. However, if you resect the terminal ileum, you lose those unique transporters for bile salts and B12. The jejunum simply cannot compensate for that loss.
So losing the terminal ileum means guaranteed problems with bile salts and B12 absorption.
Precisely. A reduced pool of bile salts recirculating the body means less effective fat digestion and absorption throughout the entire small intestine. This can lead to potential deficiencies in fat-soluble vitamins A, D, E, K, and steatorrhea, which is fatty stools, and of course, direct deficiency of vitamin B12. The ileum also plays a crucial role in water absorption, possibly due to tighter junctions between its cells, creating a better gradient for water uptake.
Ah, okay.
This is why significant ileal resection is a really common cause of severe, often difficult to manage diarrhea.
So even that seemingly small terminal section is absolutely indispensable for these specific functions. It's not just about length.
It truly is. It just underscores the finely tuned nature of this organ. And beyond digestion and absorption, the small intestine also contributes to lipoprotein metabolism, synthesizing HDL, LDL, VLDL, to transport absorbed dietary fats into the systemic circulation via the lymphatics.
Okay.
And it produces several important intestinal hormones like GLP-1, GLP-2, peptide YY, and Meckel. These interact with the enteric nervous system to modulate gut function, growth, and even influence appetite and glucose metabolism. It's an incredibly sophisticated factory and communication hub.
That gives us a really solid foundation on the structure and function. It's amazing, actually. Now let's delve into what happens when things go wrong. The text first addresses inflammatory and infectious conditions.
Right, and the source makes an important distinction here between inflammatory bowel disease, or IBD, and infective causes of enteritis. IBD is defined as idiopathic inflammation of the intestine, meaning the cause isn't known.
Idiopathic, right. Unknown cause.
Exactly, and by definition, this excludes inflammation due to infection or ischemia, lack of blood flow.
And is there a specific IBD that affects the small intestine predominantly?
Yes. Crohn's disease, or CD, is the primary IBD that can affect any part of the GI tract, from mouth to anus, but it frequently involves the small intestine, particularly the terminal ileum. The text points back to the historical description of regional ileitis by Crohn, Ginsberg, and Oppenheimer back in 1932, highlighting this specific manifestation.
Okay, so Crohn's is the main IBD player for the small bowel, but the source spends a good bit of time detailing specific infections that cause enteritis. It lists several key culprits.
It does. First up is Campylobacter, specifically Campylobacter jejuni. This spiral-shaped gram-negative rod is highlighted as the most common bacterial gastroenteritis in the UK, often acquired from infected poultry.
What are the typical symptoms? Just standard food poisoning?
Well, diarrhea and abdominal pain are standard, yes. But what's important for clinicians, and something the source makes really clear, is that severe cases can actually mimic other serious abdominal conditions,
Mimic. Like what?
like acute appendicitis or even severe ulcerative colitis. Sometimes it presents with rectal bleeding and ulceration. This overlap can make diagnosis tricky initially.
So it's not just simple food poisoning sometimes. It can look like something much worse. That's important.
Exactly. Diagnosis relies on stool culture, but the organism is fastidious, meaning it's tricky to grow in the lab and can take several days. While usually self-limiting, rare severe complications like toxic dilation of the colon can occur. Treatment is generally supportive. Antibiotics usually aren't needed, but it is a notifiable disease, meaning it has to be reported to public health authorities.
Okay. Next on the list is Yersinia.
Right, Yersinia enterocolitica, another gram-negative rod. This one has a specific predilection for the terminal ileum, the appendix, the ascending colon, and importantly, the mesenteric lymph nodes nearby.
Okay.
What's fascinating here, and a key takeaway, is that it causes a type of inflammation characterized by granulomas, these clusters of immune cells, and this pathologically mimics Crohn's disease.
Ah, another mimic, but this time at the tissue level, under the microscope. So symptoms can look like gastroenteritis or persist as terminal ileitis.
Right. Fever and gastroenteritis are common, and it can linger as a terminal ileitis. Complications like perforation, while rare, can happen. Diagnosis can be by stool culture, but the text emphasizes that it's more often diagnosed serologically by detecting antibodies in the blood.
Okay.
If encountered during surgery, the affected terminal ileum and mesenteric nodes will be thickened and inflamed, and a lymph node biopsy can help differentiate it from Crohn's.
How is Yersinia usually treated? Does it need antibiotics?
Like Campylobacter, it's typically self-limiting. However, it does respond to antibiotics such as cotrimoxazole or chloramphenicol if treatment is actually required.
Then there's the big one, Salmonella, and its more severe forms, typhoid and paratyphoid.
Right, a whole family. Salmonella gastroenteritis, often caused by S. enteritis leaked to poultry, is usually a relatively mild, self-limiting illness with headache, fever, and watery diarrhea. More severe cases might need hospitalization for IV fluids and sometimes antibiotics. Diagnosis is typically via stool culture. The text notes that similar illnesses can be caused by Shigella and certain enteropathogenic strains of E. coli.
And typhoid fever. That's a different ballgame altogether.
Absolutely. Caused by Salmonella enterica, specifically serotype typhi, typhoid fever is a systemic infection. It's much more serious. It has a longer incubation period, maybe 10-20 days, starting with fever and abdominal pain, and can progress to abdominal distension, diarrhea, splenomegaly, that's large spleen, and those characteristic rose spots on the abdomen.
Rose spots, what are they?
They're small pinkish spots caused by inflammation of small blood vessels, of vasculitis. It shows the infection is affecting the whole body, not just the gut.
So it's really affecting the whole system.
Precisely, it's a severe systemic illness. Diagnosis relies on culturing the bacteria from blood or stool. Treatment is with antibiotics, commonly chloramphenicol according to this source, although others are used now too. The critical point the source highlights here is the potential for significant surgical complications.
Surgical complications from typhoid? Like what?
These include paralytic ileus, where the bowel stops moving, intestinal hemorrhage, free ileal perforation, a hole right through the ileum into the abdominal cavity and cholecystitis, inflammation of the gallbladder.
And the systemic infection itself can be very severe, leading to septic shock, right?
Yes, severe gram-negative sepsis is a major risk, and the infection can spread, causing metastatic sepsis, infecting other sites like joints, septic arthritis or osteomyelitis, the brain, meningitis, encephalitis, or leading to disseminated intravascular coagulation, DIC, which is a serious clotting problem, or pancreatitis.
The text specifically mentions the surgical management of a typhoid ulcer perforation. That sounds serious.
It is. This is a key clinical point. Perforation typically occurs in the third week of illness, so sometimes it's the first sign. The ulcer has a characteristic shape, usually parallel to the long axis of the gut, and is located in the distal ileum. This is a surgical emergency requiring immediate laparotomy opening the abdomen to wash out the contamination and close the perforation.
Do they usually cut out that bit of bowel?
The text advises avoiding formal bowel resection if possible, likely due to the inflamed and potentially fragile state of the surrounding bowel and typhoid. Just closing the hole is preferred.
And for patients who are really unstable?
Yes. A crucial strategy for severely ill or septic patients is to exteriorize the perforated segment, basically. Bring it temporarily outside the abdomen as a stoma and deal with closing the hole or rejoining the bowel later when the patient is much more stable.
A damage control approach.
Exactly. And paratyphoid fever, caused by S. paratyphi is clinically similar to typhoid and treated the same way.
Okay. Moving on to tuberculosis of the intestine. This isn't the first place I'd think of TB showing up. Usually think lungs.
You're right, lungs are most common, but TB can indeed affect any part of the GI tract. It commonly involves the ileum, the proximal colon, and the peritoneum, the lining of the abdominal cavity. The source describes two principal ways it can present, which is critical to understand because they look quite different from each other.
What's the first form?
The first is ulcerative tuberculosis. This is usually secondary to active pulmonary PB, often from swallowing infected sputum. In the terminal ileum, you'll typically find multiple ulcers that lie transversely across the bowel wall, not along its length. And the outer surface, the serosa, is thickened, reddened, and might be studded with tiny white nodules called tubercles.
So ulcers causing potential problems. What are the symptoms with this type?
Diarrhea and weight loss are common. Complications include subacute bowel obstruction due to the narrowing caused by the ulcers and scarring, local perforation, or fistula formation abnormal connections. Imaging like a barium follow-through or CT might show affected segments of distal ileum, cecum, or sending colon that appear narrowed or don't fill properly with contrast. The text notes imaging can show dilation upstream, proximal to a stricture, which is typical of obstruction.
And how is this ulcerative form treated?
Antituberculous chemotherapy, the standard TB drug regimens, is usually very effective and curative, provided the underlying pulmonary TB is also being treated properly. Surgery is rarely needed, really reserved only for severe complications like a frank perforation or a complete unresolving bowel obstruction.
What's the second form then? You said they're quite different.
That's hyperplastic tuberculosis. This form is thought to occur when individuals with relatively high resistance to the bacteria ingest M. tuberculosis, perhaps from contaminated milk in the past, for example. It usually presents as a mass in the ileocecal region, though other lesions in the distal ileum are possible.
A mass.
Yes, the pathology is different here. Instead of ulcers, the infection in the lymphoid follicles leads to chronic exuberant inflammation, causing significant thickening of the bowel wall and a consequent narrowing of the lumen. It forms a hard, thickened segment.
So thickening instead of ulceration causing the narrowing this time.
Exactly. And a key point differentiating it from Crohn's disease, which it can strongly resemble clinically and radiologically, is that abscess and fistula formation are uncommon in hyperplastic TB. There's often early and prominent involvement of regional lymph nodes, which can develop case-seated necrosis, that characteristic cheesy breakdown typical of TB.
And the symptoms, how does this present?
Because of the narrowed lumen and partial obstruction, patients typically experience intermittent attacks of abdominal pain and sometimes diarrhea. The obstruction leads to stasis of contents upstream, causing bacterial overgrowth.
Which we talked about earlier.
Right, which in turn contributes to malabsorption, styria, anemia, and weight loss. Patients might present with a palpable mass in the right lower abdomen, the right iliac fossa, and general symptoms of poor health, like fatigue and low-grade fever.
So it can look like a tumor or a mass, making the differential diagnosis quite broad. Could be an appendix mass, lymphoma, cecum cancer, or Crohn's disease, as you said.
Absolutely. The text really stresses this diagnostic challenge. Imaging, like a barium study, will often show a long, narrow-filling defect in the terminal ileum, which can look very similar to Crohn's string sign. CT will reveal the narrowed segment, distension upstream, and the associated enlarged lymph nodes, lymphadenopathy.
How is hyperplastic TB treated then, if it looks like a mass?
Well, if the diagnosis is clear, perhaps from a biopsy or other features, and there's no significant obstruction, antituberculous medication is the mainstay and can be curative. However, if there's significant obstruction, or if the diagnosis remains unclear and could be Crohn's, lymphoma, or cancer, surgical resection, typically an ileocecal resection to remove the mass, is often necessary. This serves both to relieve the obstruction and, critically, to get a definitive tissue diagnosis.
Okay, that makes sense. Now, let's touch on actinomycosis. The source describes this as a rare abdominal infection.
It is relatively rare, caused by the bacterium Actinomyces israeli, which is actually a normal inhabitant of the mouth and gut sometimes. A classic way it presents in the abdomen, as noted in the text, is several weeks after an apparently simple perforated appendicitis.
After appendicitis, why then?
The thinking is the appendicitis allows the bacteria to get into tissues where they normally wouldn't cause trouble. Instead of healing cleanly, an abscess forms and then slowly, relentlessly spreads, often involving the retroperitoneal space behind the abdominal lining and the abdominal wall itself. This leads to multiple indurated, meaning hardened, almost woody-feeling, discharging sinuses opening onto the skin.
Indurated, okay. That woody feel sounds distinctive.
It is. The discharge from these sinuses can change from thin and watery initially to thicker and malodorous later. Sometimes it contains the characteristic sulfur granules, tiny yellow specks that are actually clumps of the bacteria, not actual sulfur. You can get secondary fistulas forming, but a key distinguishing feature from TB or Crohn's, and something the text highlights, is that the mesenteric lymph nodes are typically not involved, and the lumen of the intestine is usually not significantly narrowed.
That's a really important diagnostic contrast again. No lymph nodes, no narrowing.
Exactly. A rare but serious complication is spread via the portal vein to the liver, causing liver abscesses. Diagnosis is often made by identifying those sulfur granules in the pus under a microscope. Treatment requires prolonged high-dose antibiotics, usually penicillin or cotrimoxazole, for weeks or even months.
Finally, in this section on infection and inflammation, the source briefly covers HIV and opportunistic infections in the small intestine.
Yes, advanced HIV infection and AIDS are associated with various GI complications due to the severely compromised immune system. Opportunistic organisms, which normally wouldn't cause significant illness in a healthy person, can cause severe persistent gastroenteritis.
Which kinds of organisms?
The text lists a whole range. Bacterial ones like Salmonella, Shigella, Yersinia, Campylobacter, and MAI Mycobacterium avium intracellulare, which is related to TB, viral causes like cytomegalovirus, CMV, protozoal ones like Cryptosporidium and Giardia, and even fungal infections like Candida albicans.
So basically, the small bowel becomes vulnerable to a wide range of pathogens when the immune system is severely weakened by HIV.
Exactly. The source also mentions a specific HIV enteropathy, which is thought to be a direct effect of the virus on the intestinal lining itself, causing diarrhea and malabsorption even without a specific opportunistic infection. Management focuses on identifying and treating the specific organism involved, if possible. The text advises that surgery should generally be avoided in these patients whenever possible, due to their underlying immunocompromise and often poor healing.
That gives us a really comprehensive overview of the inflammatory and infectious landscape in the small intestine. It shows how various pathogens and inflammatory processes can really wreak havoc on this vital organ. Let's shift gears now to discuss tumors of the small intestine.
Okay, small bowel tumors are relatively rare compared to tumors elsewhere in the GI tract, like the colon or stomach. They account for less than 10% of all gastrointestinal neoplasms. A significant point made by the text is that they tend to present late.
Why do they often present so late? Is it just because the small bowel is so long?
That's likely a big part of it, yeah. The small intestine is long and mobile, kind of floating in the abdomen. Tumors can grow quite large before they cause noticeable symptoms like significant obstruction or bleeding. Often, they're discovered incidentally, maybe during surgery performed for another reason, like investigating chronic abdominal pain or an apparent obstruction that turns out to be tumor-related.
So they can kind of hide for a long time. The source discusses both benign, non-cancerous, and malignant tumors.
Yes, and benign tumors are actually the majority. These include types like adenomas, similar to colon polyps, lipomas, which are fatty tumors, hemangiomas, tumors made of blood vessels, and neurogenic tumors arising from nerve tissue.
And often these benign ones don't cause any symptoms at all.
Many are asymptomatic and found purely by chance. When they do cause symptoms, it's typically due to mechanical issues, causing intussusception, where the bowel telescopes with the tumor acting as the leading edge.
Right, pulling it in.
Exactly. Or causing small bowel obstruction by blocking the lumen, or causing bleeding. The bleeding can be slow and chronic, leading to anemia, or more overt with visible blood in the stool.
Diagnosis sounds challenging if they're small or not causing a major blockage.
It can be.
Yeah.
Standard imaging like CT scans or barium studies aren't always great at picking them up easily, especially smaller ones. However, newer techniques like capsule endoscopy where you swallow a tiny camera.
The pill camera.
Yeah, the pill cam. Or small bowel endoscopy using a long scope, if available, can be more successful in visualizing them. For benign lesions that are causing symptoms, the treatment is typically surgical resection of the affected segment of the small bowel.
The source highlights a specific condition linked to polyps. Poitz-Jeghers syndrome. This sounds important.
It is. This is a key syndrome to know about. It's an autosomal dominant inherited condition, meaning it runs in families. Its characteristic external markers are melanin spots, small, dark, freckle-like spots, typically found on the mouth and lips, but also sometimes on the fingers, toes, and around the anus.
Okay, those spots are a clue. And internally?
Internally, these patients develop multiple hamartomatous polyps throughout the small bowel and often the colon as well.
Hamartomatous, that's a specific type of polyp, isn't it? Not cancerous.
Right. It means they are benign, tumor-like malformations that arise from faulty development of the normal tissue in that organ, rather than being truly neoplastic growths like adenomas. The source notes a genetic link in some cases, specifically mutations in the STK11 gene on chromosome 19.
And these patients have other risks beyond just the polyps themselves. This sounds more serious than just benign polyps.
Crucially, yes. Long-term follow-up studies have shown a significantly reduced survival rate in Poitz-Jeghers patients. This isn't just from complications caused by the polyps, such as bowel obstruction due to intussusception, but also from a predisposition to developing a range of other cancers later in life.
What kinds of cancers?
Cancers of the colon, stomach, pancreas, breast, ovary, lung, and testes are all reported to be increased. This increased cancer risk necessitates regular surveillance for these patients. Colonoscopies, mammograms, pelvic exams for women, etc.
Do the hamartomatous polyps themselves become malignant often?
Interestingly, malignant transformation within the hamartomatous polyps themselves is actually uncommon, despite the patient's overall increased risk of developing other types of cancer elsewhere. Surgical resection of polyps or affected bowel segments is usually indicated if they cause significant or recurrent bleeding or if they are causing intussusception.
How are these polyps removed surgically?
The source mentions several approaches. You can make an incision directly into the bowel over the polyp and enterotomy to remove it. During a laparotomy, open surgery, a colonoscope can sometimes be inserted through an enterotomy to snare multiple polyps further down. Or, if a segment of bowel is heavily involved with numerous large polyps, surgical resection of that entire segment might be necessary.
Okay, so even benign conditions can be quite complex. What about malignant tumors? The source lists 4 main types, making up almost all of them.
Right, these 4 account for over 99% of small bowel cancers. Adenocarcinoma, neuroendocrine tumors, often still called carcinoid tumors, lymphoma, and gastrointestinal stromal tumors.
Yes.
Let's start with adenocarcinoma. That sounds like the typical glandular type cancer we see elsewhere.
It is. Small bowel adenocarcinoma is the most common type of malignancy found there. It occurs more frequently in the jejunum than the ileum. While the exact cause isn't fully known, the text highlights that it's significantly more common in patients with certain predisposing conditions.
Which conditions raise the risk?
Crohn's disease, coeliac disease, familial adenomatous polyposis, FAP, hereditary non-polyposis colon cancer, HNPCC, also known as Lynch syndrome, and Poitz-Jeghers syndrome. Recognizing these risk factors is really key for identifying patients who might need closer monitoring.
So people with those specific conditions are at higher risk for this otherwise rare cancer. How does it typically present? What are the symptoms?
Presentation is often similar to symptomatic benign tumors. Anemia from chronic, slow bleeding, overt GI bleeding, intussusception, or causing bowel obstruction. The prognosis, unfortunately, is generally poor, and the text specifically notes it's particularly poor in patients who also have Crohn's disease.
Why is the prognosis worse in Crohn's patients specifically?
It's thought to be because the symptoms of small bowel adenocarcinoma, things like abdominal pain, weight loss, changes in bowel habit, partial obstruction, can easily be mistaken for a flare-up or a complication of their underlying Crohn's disease.
So it gets missed, or diagnosis is delayed.
Exactly. This often leads to significant delays in diagnosis and treatment, by which time the cancer is typically more advanced and harder to cure.
What's the standard surgical treatment?
Surgical resection is the mainstay. The text specifies removing at least 5 centimeters of normal-looking bowel on either side of the tumor, along with the corresponding segment of mesentery, to remove the potential lymphatic spread in that tissue. For tumors located in the distal ileum, near the colon, a right hemicolectomy removing the end of the ileum, the cecum, and the right side of the colon is often necessary because they share a common blood supply and lymphatic drainage.
Okay. Next are neuroendocrine tumors, or NETs. The source mentions they were previously called carcinoid.
Yes, that term carcinoid is still widely used, but neuroendocrine tumor, NET, is the more modern and accurate classification. These tumors can arise anywhere along the GI tract, but they are most frequently found in the appendix, the ileum, and the rectum, in that descending order of frequency.
Where they actually originate from? Which cells?
They arise from specialized enterochromatin cells, also known sometimes as Kolchitsky cells, which are found scattered at the base of the intestinal crypts, the glands, and the bowel lining. An interesting point is that the primary tumor in the bowel wall is often quite small, sometimes only millimeters in size, but they have a propensity for early spread to the regional lymph nodes, and often to the liver.
So it's small primary, but early spread.
Often, yes. The text also notes that multiple primary tumors are present in the small bowel in up to 1/3 of net cases.
The source mentions they can cause fibrosis, scarring.
Yes, that's a characteristic feature. They may induce a dense fibrous reaction called desmoplasia in the surrounding tissues, and particularly in the mesentery. This fibrosis can cause distortion and scarring of the bowel loops, sometimes leading to kinking and obstruction, and it can give a specific stellate or starburst appearance on radiological scans.
And the classic carcinoid syndrome. What causes that?
This is the clinical syndrome that occurs when these tumors produce and release excessive amounts of vasoactive substances into the bloodstream. The most common one is serotonin, also called 5-hydroxytryptamine or 5-HT, but they can also produce histamine, prostaglandins, kallikrein, and others. Critically, carcinoid syndrome typically only occurs when the tumor has metastasized or spread to the liver.
Why only when it's metastasized to the liver? Why not from the primary tumor?
Because the normal liver contains enzymes, like monoamine oxidase, that effectively metabolize and inactivate these vasoactive substances as the blood drains from the gut via the portal vein. So substances released by a primary tumor in the gut are usually filtered out and broken down by the liver before they can reach the rest of the body.
Ah, I see.
But when the tumor cells are actually in the liver itself, as metastases, they release these substances directly into the hepatic veins, which drain into the systemic circulation, bypassing the liver's first-pass metabolism. This allows them to cause the systemic symptoms of the syndrome.
What are those symptoms? What does carcinoid syndrome look like?
The text lists the key features: episodic reddish-blue cyanosis, a kind of dusky flushing of the skin, especially face and neck, characteristic slushing attacks, often triggered by things like alcohol, stress, or certain foods, persistent diarrhea, sometimes very watery and explosive, excessive borborygmy, loud, rumbling bowel sounds,
Right.
asthmatic attacks or wheezing due to bronchoconstriction, and eventually, over time, fibrotic changes can affect the heart valves, particularly causing pulmonary and tricuspid valve stenosis and regurgitation, leading to right-sided heart failure.
Wow, that sounds like a really complex and multi-system syndrome to diagnose and manage.
It absolutely is. Diagnosis and assessment of the extended disease often involves specialized imaging techniques like octreotide scanning. This uses a radioactive tracer attached to octreotide, which binds to somatostatin receptors that are often highly expressed on net cells, allowing visualization of tumors, including ones not seen on other scans.
So it lights up the tumors.
Essentially, yes. Plasma chromogranin A, a protein released by neuroendocrine cells, is a useful blood marker for monitoring for recurrence after treatment, and also has some prognostic value.
How are these nets treated?
Surgical resection of the primary tumor and any involved regional lymph node metastases is the mainstay for localized disease, although the incidence of recurrence can be significant. Surgical resection of liver metastases, debulking, is also undertaken in selected cases, as it can improve symptoms and potentially survival. For managing the symptoms of carcinoid syndrome, particularly the flushing and diarrhea, the text notes that treatment has been really transformed by the use of octreotide and other somatostatin analogs.
How does octreotide help with the syndrome?
It binds to the somatostatin receptors on the tumor cells and inhibits the synthesis and release of those vasoactive peptides, which dramatically reduces the frequency and severity of the flushing and diarrhea symptoms for many patients.
So it controls the hormone release?
Exactly. Octreotide is also often given during surgery on nets, particularly if manipulating the tumor, to prevent a potentially dangerous carcinoid crisis. This is a severe, potentially life-threatening systemic reaction caused by the sudden release of a massive bolus of these vasoactive substances when the tumor is handled or stressed.
So it's both a symptom manager and a crucial protective agent during surgery. What about their growth rate and responsiveness to other therapies like chemo?
Nets generally grow much slower than most other metastatic malignancies, like adenocarcinomas. Patients can often live for many years even with widespread metastatic disease. However, they are typically quite resistant to conventional chemotherapy and radiotherapy. The source refers to other chapters for more detail, but that covers the key points on NETs from this text.
Okay, next up is lymphoma in the small bowel.
Right. Lymphoma, which is a cancer of the lymphatic system, can arise primarily within the bowel wall itself. Or, perhaps more commonly, it can occur as part of systemic lymphoma that involves lymph nodes and other organs throughout the body, including secondary involvement of the small intestine.
Are there risk factors?
Yes, the text points out that there is an increased incidence of small bowel lymphoma in patients with Crohn's disease and also in patients with certain immunodeficiency syndromes, including HIV/AIDS and post-transplant patients on immunosuppression.
Is there a specific type of lymphoma usually involved?
The classification of lymphomas is quite complex, as the source notes, and beyond its scope. However, in Western countries, most primary small bowel lymphomas are non-Hodgkin's B-cell lymphomas. Hodgkin's lymphoma, another major type, is actually rare in the small bowel.
How does lymphoma typically present when it affects the small bowel? What are the symptoms?
Symptoms are often quite nonspecific, unfortunately. They can include anemia from bleeding, overt bleeding, anorexia, loss of appetite, weight loss, abdominal pain, or sometimes complications like perforation or obstruction. The text mentions a few specific subtypes that are clinically important to be aware of.
Like which ones?
Well, there's small bowel T-cell lymphoma, which is sometimes specifically associated with long-standing, untreated, or refractory coeliac disease. It can present with worsening diarrhea, unexplained fever, pyrexia of unknown origin, or symptoms related to localized obstruction or perforation.
Okay.
Then there's Mediterranean lymphoma, also known as immunoproliferative small intestinal disease, IPSID, a specific form found mostly in North Africa and the Middle East that is often widespread at diagnosis and associated with chronic infection. And Burkitt's lymphoma, which is a very aggressive, fast-growing type of B-cell lymphoma, can particularly affect the ileocecal region, especially in children in certain parts of Africa, but also occurs sporadically elsewhere.
So a varied presentation depending on the specific type. What's the main treatment approach for small bowel lymphoma? Is it surgery?
No, chemotherapy is the cornerstone of treatment for virtually all types of lymphoma, regardless of where they occur. Surgery is generally reserved for managing acute complications like obstruction, perforation, or significant uncontrollable bleeding. Sometimes resection is needed for diagnosis if a biopsy isn't conclusive.
Okay, chemo first, surgery for problems. Finally, the fourth type, gastrointestinal stromal tumors, or GISTs. These sound different.
They are distinct, yes. GS are mesenchymal tumors. That means they arise from the connective tissue layers within the bowel wall, specifically from cells called the interstitial cells of Koschel, which are like the pacemaker cells of the gut.
Ah, not from the lining cells like adenocarcinoma.
Exactly. They're different biologically. Determining whether a specific GS is benign or malignant can actually be challenging based solely on its microscopic appearance, histology. The text notes that factors associated with a higher malignant potential, meaning more likely to behave aggressively and metastasize, include increasing tumor size and high levels of staining for a particular protein called CoKit, also known as CD117, which is a marker for these cells.
Where are GISTs most commonly found?
While they can occur anywhere throughout the GI tract, from the esophagus down to the rectum, they are most common in the stomach, followed by the small intestine. They are most frequently diagnosed in individuals between 50 and 70 years old. The underlying cause is generally unknown, but there is an increased risk in patients with a genetic condition called neurofibromatosis type 1.
What symptoms do they cause? Or can they be silent?
They can definitely be asymptomatic and discovered instantly on imaging like a CT scan done for other reasons. When they do cause symptoms, it can include vague things like lethargy or abdominal discomfort, or more specific symptoms like abdominal pain, nausea, or bleeding. The bleeding might manifest as vomiting blood, hematemesis, or passing dark, tarry stools, melena.
How are GISTs treated? Is it surgery again?
Surgery is considered the most effective treatment for localized GISTs. These tumors are typically resistant to conventional radiotherapy and not very sensitive to standard chemotherapy regimens used for other cancers. However, a really significant advance, mentioned clearly in the text, is the development of targeted therapy with a drug called imatinib.
Imatinib. That's a specific drug for GISTs.
Yes, it's a tyrosine kinase inhibitor. It specifically targets the abnormal signaling caused by mutations in the CoKit gene, which drive the growth of most GISTs. Imatinib has been shown to be highly effective in treating advanced metastatic GISTs, significantly improving survival. It may also play a role as adjuvant therapy after surgery, to reduce the risk of recurrence.
Can it be used before surgery?
Yes, it can also be used preoperatively in a neoadjuvant setting to try and shrink larger tumors to make surgery easier or more feasible.
Is there a risk associated with using imatinib to shrink a gist before operating?
Yes, there is a key risk highlighted in the source. As the tumor shrinks rapidly in response to imatinib, as it involutes, it may actually become fragile and perforate, spilling tumor contents into the abdomen and leading to a surgical emergency. So while it's often beneficial for shrinking the tumor, this potential complication needs to be anticipated and managed carefully. The text refers to other chapters for more comprehensive information on Jesus and their management.
That's quite a spectrum of tumors affecting the small intestine, each with really unique origins, behaviors, and treatment approaches. It really shows the depth of knowledge needed to diagnose and manage them effectively, doesn't it?
Indeed, it's not a simple area. Now, perhaps we should shift our focus to structural anomalies, problems with the physical architecture of the bowel, and the significant malabsorption issues that can result from these or other causes.
Structural anomalies, you mean things like pouches or narrowings, that kind of thing.
Exactly. The source first discusses intestinal diverticula, which are basically hollow outpouchings of the bowel wall. These can occur throughout the GI tract, but when we talk about small bowel diverticula, they can be either congenital, present from birth, or acquired, developing later in life.
What's the main difference between congenital and acquired diverticula in the small bowel?
Congenital diverticula involve all three layers, or coats, of the bowel wall and the outpouching mucosa, submucosa, and the muscularis externa. The classic example here, and one we'll definitely delve into in more detail, is Meckel's diverticulum.
Okay. And acquired ones?
Acquired diverticula, on the other hand, are typically formed by just the intermucosal and submucosal layers herniating or pushing out through a defect or weak spot in the muscular layer of the bowel wall. They're sometimes called false diverticula because they don't contain all layers.
So, like the inner lining pushing through a weak spot in the muscle wall.
That's a good way to think of it. Acquired small bowel diverticula are often found in the jejunum and tend to arise from the mesenteric side of the bowel, the side where the blood vessels penetrate the bowel wall, creating potential points of weakness in the muscle layer.
Okay. Are they common?
They vary in size, are frequently multiple rather than single, and are often asymptomatic, discovered incidentally during surgery or imaging for unrelated reasons.
But they can definitely cause problems, right?
They certainly can. A significant issue, which the text discusses quite clearly, is malabsorption caused by bacterial overgrowth within these stagnant pouches. They effectively create blind loops where intestinal contents can pool, allowing bacteria to multiply excessively.
Ah, the bacterial overgrowth thing again?
Exactly. They can also present acutely if they become inflamed, diverticulitis, similar to colonic diverticulitis, or if they perforate, leading to peritonitis. Bleeding from a jejunal diverticulum is possible, but seems to be less common than bleeding from diverticula in the large bowel, like the sigmoid colon.
If malabsorption is a problem due to the bacterial overgrowth, how is that typically treated?
Well, if the jejunal diverticulosis is limited to a specific segment of the jejunum, elective surgical resection of that segment can be very effective. It removes the site of stasis and overgrowth, thereby treating the malabsorption.
Okay, cut out the bad bit. What if one perforates?
If a diverticulum perforates, that's an acute emergency requiring surgery. This usually involves resection of the affected segment of bowel. The decision then is whether to reconnect the bowel ends immediately in anastomosis or to create a temporary stoma, bringing the upstream end out to the skin. That decision depends on factors like the degree of abdominal contamination, the patient's overall stability, and the resources available to manage a potentially high-output jejunostomy.
And what about if someone has really extensive jejunal diverticulosis where much of the jejunum is involved? Resection doesn't sound like a great option then.
No, this is where treatment gets very challenging. If extensive proximal small intestine is involved, resection is often not feasible because you'd remove too much essential bowel needed for absorption. In these difficult cases, management often relies on prolonged and often rotating courses of oral antibiotics.
To keep the bacteria down.
Exactly. Antibiotics like metronidazole, ciprofloxacin, tetracycline, or rifaximin are used to try and suppress the bacterial overgrowth. However, this may not fully resolve all the symptoms of malabsorption or discomfort. Even performing a limited resection might not fully address the widespread stasis issues if diverticula remain elsewhere.
That sounds like a really difficult chronic condition to live with. Now, let's talk specifically about Meckel's diverticulum, that specific congenital type you mentioned. It feels like this is a classic surgical teaching point, always comes up.
It absolutely is, and the source gives it the attention it deserves because it's common and can cause significant problems. A Meckel's diverticulum is the most common congenital anomaly of the entire gastrointestinal tract. It represents a persistent remnant of the vitellointestinal duct, which in the embryo connected the developing gut to the yolk sac.
And there's that famous rule of twos associated with it, right?
Yes, the text prominently features the rule of twos because it's a really handy mnemonic for recalling the key statistics. It occurs in approximately 2% of the population. It's typically located on the anticenteric side of the ileum. That's the side opposite where the mesentery attaches about 2 feet or roughly 60 centimeters proximal to the ileocecal valve.
Okay, 2% prevalence, 2 feet from the valve.
It's classically about 2 inches or 5 centimeters long. And importantly, about 20% of those that become symptomatic contain heterotopic epithelium, meaning tissue that doesn't normally belong in the ileum, most commonly stomach lining.
So 2% prevalence, 2 feet from the valve, 2 inches long, and 20% symptomatic have that ectopic tissue. That's easy to remember.
It is, yeah. As a congenital diverticulum, it contains all 3 layers of the bowel wall and typically has its own dedicated blood supply arising from the SMA branches in the mesentery. The text notes that, much like the appendix, it's prone to obstruction at its base and subsequent inflammation, Meckel's diverticulitis.
And there's a practical clinical tip about it in surgery for appendicitis.
Yes, a very important one. If a surgeon is operating for suspected acute appendicitis and finds a perfectly normal appendix, especially if there's unexpected free fluid or pus in the abdomen, it's standard practice to actively look for an inflamed or perforated Meckel's diverticulum as the alternative cause of the patient's symptoms, usually by examining the last meter or so of the ileum.
You mentioned heterotopic epithelium, most commonly gastric tissue. Why is that specific finding so important clinically?
Because heterotopic gastric mucosa located within the Meckel's diverticulum produces acid, just like the lining of the stomach does. This acid is highly corrosive to the surrounding normal small bowel lining, ileal mucosa, within the diverticulum, or at its junction with the ileum, as the ileum isn't designed to withstand that level of acidity. This leads to peptic ulceration.
The acid causes an ulcer, just like a stomach ulcer, but in the wrong place. And how does this present clinically?
Well, the vast majority of Meckel's diverticula remain asymptomatic throughout life and are notoriously difficult to visualize on standard contrast radiology like barium studies. However, when they do cause trouble, they can present in several distinct ways. Hemorrhage, or bleeding, is one of the most common presentations, particularly in children and young adults. This is usually due to that peptic ulceration caused by the heterotopic gastric mucosa. It typically presents as painless, often quite brisk, dark rectal bleeding, or melena, black tarry stools.
Painless bleeding is a key sign then, especially in a younger person.
Yes. If standard endoscopy of the stomach, duodenum, and colon is normal, ruling out those more common bleeding sites, a specific nuclear medicine scan called a technetium 99-meter pertechnetate scan, often called a Meckel scan, can help diagnose it. This tracer is taken up by gastric mucosal cells, so it can highlight the heterotopic tissue in the diverticulum.
Okay. What other ways can it present?
Diverticulitis is another common presentation. Inflammation of the Meckels can exactly mimic the symptoms of acute appendicitis, right? Or quadrant pain, fever, nausea. If the inflamed diverticulum perforates, it can present with signs of peritonitis, sometimes resembling a perforated duodenal ulcer if the pain is more central or upper abdominal. Intussusception is another classic, particularly in children, where the Meckel's itself, especially if inverted or thickened, acts as the lead point for the bowel telescoping into itself, usually ileoreal or ileocolic.
Right.
Chronic ulceration, even without massive bleeding, can cause intermittent abdominal pain, typically felt around the umbilicus.
And the umbilical pain links back to its embryonic origin from the midgut, like we discussed with referred pain.
Precisely. Intestinal obstruction can also occur. Sometimes a fibrous band, which is another remnant of the vitellointestinal duct, connects the tip of the diverticulum to the back of the umbilicus. This band can directly compress or kink the small bowel, causing obstruction, or it can act as a pivot point around which a loop of bowel twists, causing a volvulus. And of course, simple perforation of the diverticulum itself due to inflammation or ulceration is a potential risk leading to peritonitis.
What if a Meckel's is found incidentally, just by chance during surgery for something else? Should it always be removed?
The text advises a pragmatic approach. If it has a wide base, allowing easy emptying, and its wall is not thickened or abnormal looking, it can usually be left alone safely, especially in an older patient where the lifetime risk of complications is lower. However, if there's any doubt if the base is narrow, if the wall feels thickened or nodular, suggesting possible heterotopic tissue, it's generally considered safer to remove it prophylactically to prevent future complications. The source also mentions Litter's hernia, which is the specific term for finding a Meckel's diverticulum trapped within an inguinal or femoral hernia sac. It notes, as a historical aside, that Litter described this finding before Meckel even described the diverticulum itself.
Interesting bit of history. So if it does need removing, how is a Meckel's diverticulectomy typically done? The source outlines the technique, and it sounds like it's different from taking out an appendix.
Yes, this is an important surgical detail they emphasize. If the diverticulum have a relatively broad base, where it joins the ileum, the text specifically warns against simply amputating it flush at the base, and then invaginating or oversewing the stump into the bowel lumen, which is a common technique for an appendix stump.
Why is that technique bad for a Meckel's?
Because it carries a significant risk of creating a stricture or narrowing at that point in the ileum. And perhaps more importantly, it risks leaving behind islands of that heterotopic gastric tissue right at the base, which could continue to secrete acid and cause ulceration or bleeding later on.
So that common appendix technique isn't safe here. What is the recommended approach?
The safer approaches described are either to carefully excise the diverticulum along with a small ellipse of the adjacent ileal wall where it attaches, and then suture the resulting defect in the ileal wall closed transversely to avoid narrowing the lumen, or, alternatively, to perform a limited formal small bowel resection, removing a short segment of the ileum that includes the entire base of the diverticulum and then joining the bowel ends back together with a standard anastomosis. A linear stapler cutter device can also be used effectively for this resection and anastomosis.
And if the base feels abnormal?
The text adds that if the base of the diverticulum feels indurated or thickened on balance, performing that limited small bowel resection and anastomosis is generally the safer option to ensure complete removal of any abnormal tissue.
Okay, that clarifies the surgical nuances. Now, moving from these structural pouches specifically to the problem of malabsorption caused by bacterial overgrowth, which we touched on briefly with jejunal diverticula, can we revisit that?
Right. So the lumen of the normal small intestine is kept relatively sterile compared to the colon, which is teeming with bacteria. This relative sterility is maintained by the constant forward propulsive movement of peristalsis, the flushing action of intestinal secretions, and the barrier effect of the ileocecal valve preventing reflux from the colon.
Okay.
However, if anything causes significant stasis, a major delay or pooling in the movement of contents through the small bowel, it can become heavily colonized by bacteria that normally reside only in the colon. This condition is often broadly termed small intestinal bacterial overgrowth, or SIBO, and sometimes historically referred to as blind loop syndrome.
Blind loop syndrome, does that mean there's literally a loop of bowel that doesn't connect properly, like after some types of surgery?
That's one cause. Certainly a surgically created loop that doesn't empty well. But the term and the concept of SIBO can be applied more broadly to any condition that causes significant stasis and allows poor bacterial clearance. The text lists examples like chronic partial small bowel obstruction from adhesions or strictures, extensive jejunal diverticulosis, as we discussed, creating stagnant pouches, or things like ileocolic fistulation, where an abnormal connection forms directly between the ileum and colon, allowing colonic bacteria to easily reflux back into the small bowel. The figure in the source shows some common types leading to this.
How does this bacterial overgrowth actually mess up absorption? What do the bacteria do?
Well, the excess bacteria, particularly in the upper small intestine, jejunum, can interfere with fat digestion and absorption quite significantly. They do this primarily by deconjugating bile salts. Bile salts need to be in their conjugated form to work properly in forming the cells, which are necessary for absorbing fats. When bacteria deconjugates them prematurely, fat absorption is impaired.
So fat malabsorption is a key feature. What else?
If the overgrowth is more prominent in the distal small intestine, ileum, the bacteria can compete with the host for dietary vitamin B12 and consume it, leading to B12 deficiency over time. The text notes that the effect on protein and carbohydrate absorption is usually less pronounced than the impact on fat and B12 absorption.
And the symptoms reflect this. What does a patient with SIBO typically experience?
The primary symptom is often stytorrhea, fatty, bulky, foul-smelling stools due to the fat malabsorption. This, over time, can lead to deficiencies in fat-soluble vitamins, A, D, E, K, and general malnutrition, causing symptoms like glossitis, sore tongue, osteomalacia, softening of bones due to vitamin D deficiency, paresthesia, pins and needles, and peripheral neuropathy. The vitamin B12 deficiency can cause megaloblastic anemia and its own set of neurological symptoms. Patients might also experience bloating, gas, and diarrhea.
How is bacterial overgrowth treated? Can it be cured?
The main medical treatment is with intermittent courses of oral antibiotics to suppress the excessive bacterial population in the small bowel. The text lists several options like metronidazole, ciprofloxacin, tetracycline, and rifaximin, sometimes suggesting that antibiotics might need to be rotated or used cyclically to reduce the risk of bacteria developing resistance over time. The definitive treatment, ideally, would be surgical correction of the underlying anatomical abnormality that's causing the stasis in the first place.
But that's not always possible, right?
Exactly. As we saw with extensive jejunal diverticulosis, or sometimes with complex adhesions or strictures, surgical correction isn't always feasible, or might carry significant risks. In those cases, managing SIBO often becomes a long-term medical challenge relying on repeated courses of antibiotics and nutritional support. The text mentions the historical poliogastrectomy, sometimes leading to a blind loop, illustrated in a diagram.
So it often becomes a chronic management issue. It's really clear how structure and function are so tightly linked here, and how disrupting the normal flow can cause these cascading problems with bacteria and absorption. Let's move on now to some of the most acute and often severe conditions affecting the small intestine. Vascular problems leading to ischemia, and ultimately the state of severe intestinal failure.
Right, these are often true surgical emergencies with potentially devastating consequences. Mesenteric ischemia basically means inadequate blood supply to the small intestine. It's classified in various ways: acute, sudden onset, or chronic, long-standing, caused by occlusion, a blockage, or non-occlusive, low-flow state, arterial or venous blockage, affecting the central main vessels or more peripheral branches.
Which blood vessels are usually involved in acute ischemia?
The superior mesenteric artery, SMA, and its branches are the most commonly affected vessels in acute arterial ischemia. Occlusion can be due to embolization, where a clot travels from elsewhere in the body, like the heart, and lodges in the SMA.
Traveling clot.
Exactly. Or it can be due to thrombosis, where a clot forms directly within the SMA, usually on top of pre-existing atherosclerotic plaque, hardening of the arteries. The text notes that blockages right at the origin of the SMA from the aorta are typically thrombotic, often linked to severe atherosclerosis. Emboli, conversely, tend to lodge a bit further downstream, frequently at the origin of the middle colic artery, which is a major branch point.
What about the other main artery, the inferior mesenteric artery?
IMA involvement causing acute ischemia is much less common and usually clinically silent because there's typically a very rich collateral blood supply network connecting the SMA and IMA territories, which can compensate if the IMA is blocked slowly. Acute SMA occlusion is the main concern.
Where do those SMA emboli typically come from? What are the sources?
The source lists the common culprits: the left atrium of the heart in patients with atrial fibrillation, AF, where clots can form due to stagnant blood flow; the left ventricle after a large heart attack if a clot forms on the damaged heart wall, a mural thrombus; infected vegetations growing on the mitral or aortic valves in endocarditis that break off, or sometimes a piece of atheromatous plaque breaking off from an aortic aneurysm upstream.
And what causes primary thrombosis in the SMA itself?
This is usually associated with severe underlying atherosclerosis narrowing the artery at its origin. Less commonly, it can be linked to certain inflammatory conditions affecting blood vessels, like vasculitides. The text mentions thromboangiitis obliterans, Berger's disease, and polyarteritis nodosa as examples.
What about clots forming in the veins, draining the intestine mesenteric venous thrombosis?
This is less common than arterial occlusion, but definitely happens. It can occur in patients with conditions that make their blood more likely to clot, hypercoagulable states, such as factor V Leiden deficiency or other inherited thrombophilias. It's also associated with portal hypertension, high pressure in the portal vein, often from liver cirrhosis, infection spreading within the portal vein system, portal pyemia, sickle cell disease, or sometimes, as the text notes, in women using the oral contraceptive pill.
And then there's non-occlusive ischemia, too, where there isn't actually a clot.
Yes, non-occlusive mesenteric ischemia, or anomali. This is a really challenging situation. Here, the major mesenteric arteries are patent, they aren't blocked by a clot, but blood flow through them is critically reduced, usually due to severe systemic illness.
Like in very sick ICU patients.
Exactly. It typically complicates critical illness, severe shock, sepsis, heart failure, major surgery, possibly due to altered blood flow regulation in the body, or severe vasoconstriction, narrowing, specifically in the splanchnic circulation, effectively shutting down blood supply to the gut as the body tries to preserve flow to the brain and heart.
Regardless of the specific cause clot, low flow, what actually happens to the bowel tissue itself when it suffers acute ischemia?
The pathology is devastating.
Yeah.
It's hemorrhagic infarction. The tissue dies due to lack of oxygen, and there's often significant bleeding within the bowel wall and the mesentery. The mucosa, the inner lining, is particularly vulnerable because it has very high metabolic demands and gets its blood supply last. It dies first.
Okay.
The bowel and mesentery become swollen, thickened, and filled with fluid, edematous, especially with venous blockage, which causes congestion. Blood-stained fluid often accumulates in the peritoneal cavity, ascites, and also within the bowel lumen itself.
How fast does this irreversible damage occur?
The changes happen frighteningly rapidly. The text emphasizes that irreversible injury, progressing from death of the inner mucosal lining to full thickness infarction, death of the entire bowel wall, usually occurs within a matter of hours, often cited as within 6 hours from the onset of complete occlusion.
Only 6 hours? That's not long at all.
Not long at all. If the main SMA trunk is blocked right at the start, a very large section of bowel is typically affected, often from just distal to the DJ flexure, where the SMA territory begins, all the way down to the splenic flexure of the colon. Blockage of a more distal branch affects a smaller, more localized segment.
So time is absolutely critical for diagnosis and intervention. What are the key clinical signs of acute mesenteric ischemia that we need to recognize?
This is arguably one of the most important things to take away from the text regarding this condition. The clinical hallmark, the most important clue for early diagnosis of acute mesenteric ischemia, is the sudden onset of severe abdominal pain that is strikingly out of proportion to the physical findings on examination.
Pain out of proportion to findings. Can you explain that a bit more?
It means the patient is clearly in agony, often writhing, describing the worst pain of their life, maybe feeling nauseous or vomiting. But when you examine their abdomen early on, it might be surprisingly soft, non-distended, with only mild or vague tenderness. There isn't the rigidity or guarding you might expect for that level of pain. This disconnect is a massive red flag.
Okay, severe pain, but the abdomen doesn't seem that bad initially. That's a really crucial diagnostic pearl to recognize, as it could be easily missed.
It is, and unfortunately this disconnect often leads to delays in diagnosis while other things are considered. The presence of known risk factors in the patient's history, like atrial fibrillation, known severe vascular disease, recent heart attack, is another crucial clue. The pain is typically sudden and located centrally in the abdomen.
What other symptoms might occur?
Early on, persistent vomiting is common. Some patients might initially have an urge to defecate, passing stool or flatus, sometimes described as an emptying phase, which might be followed later by altered blood mixed with stool. Abdominal rigidity and signs of peritonitis are late and ominous signs, indicating that infarction and possibly perforation have already occurred. Rapid circulatory collapse and shock develop due to massive fluid loss into the dying bowel and mesentery, third spacing, and the release of bacterial toxins from the compromised gut wall, sepsis.
What about investigations? What tests help diagnose this early?
Blood tests are very important. They often show a profound increase in the white blood cell count, particularly neutrophils, neutrophil leukocytosis. A severe metabolic acidosis, specifically a lactic acidosis, is a critical finding, indicating tissue hypoxia and anaerobic metabolism. So, a raised blood lactate level is a key marker, though it can be elevated in other forms of shock too.
In imaging.
Contrast-enhanced CT scanning of the abdomen, ideally with specific mesenteric, arterial, and venous phase protocols, is the most important imaging modality. It can directly visualize clots in the vessels, filling defects, or show indirect signs like absent or significantly reduced blood flow to the bowel wall, indicated by lack of contrast enhancement, thickening of the bowel wall, free fluid in the abdomen.
Okay.
And in late dire stages, it can show gas within the wall of the intestine itself, pneumatosis intestinalis, or even tracking into the mesenteric veins or the portal vein in the liver. Seeing gas in the portal vein is a particularly late and ominous sign, usually indicating extensive transmural infarction.
That sounds like a terrifying finding on a scan. How is acute mesenteric ischemia treated? It sounds like an absolute emergency.
It is. Treatment depends partly on the cause and the timing. For mesenteric venous thrombosis, if diagnosed before infarction occurs, initial treatment is usually with systemic anticoagulation, like heparin, and very close monitoring, hoping to prevent clot propagation and allow collaterals to open up. Surgery might still be needed if infarction develops. For acute arterial ischemia, if diagnosed very early, which is rare, immediate surgery laparotomy is usually required.
What do they do in surgery?
The goal is to restore blood flow if possible. This might involve opening the SMA and removing the clot, embolectomy, or performing a vascular bypass graft to get blood flow around the blockage, SMA revascularization. This requires vascular surgery expertise. Postoperative anticoagulation is essential afterwards.
But the text notes that it's often diagnosed late and the mortality rate is extremely high.
That is the unfortunate reality for acute arterial occlusion. The delay in recognizing the early signs often means that by the time surgery happens, large segments of bowel are already irreversibly necrotic, dead. If viable bowel is found, the non-viable segments must be resected. In a young, otherwise healthy patient, all the affected bowel might be resected, even if it's extensive.
What about in older, sicker patients?
In elderly or very frail patients with extensive, clearly irreversible infarction involving most of the small bowel, the situation may sadly be considered unsurvivable, and palliative care might be deemed more appropriate than aggressive, likely futile surgery. It's a very difficult situation. If there's doubt about the viability of some segments of the remaining bowel after an initial resection, a planned relook laparotomy 24 or 48 hours later is often performed to reassess the bowel and resect any further segments that have demarcated or died off.
And if extensive bowel has to be removed to save the patient's life, what are the consequences?
Patients undergoing massive small bowel resection are highly likely to develop short bowel syndrome and intestinal failure, requiring long-term intravenous nutrition, parenteral nutrition, because they simply cannot absorb enough nutrients or fluids orally. The text does note that younger patients in particular can sometimes develop remarkable adaptation of their remaining bowel over time, with the villi growing longer and the bowel diameter increasing, potentially regaining enough absorptive function to eventually live without long-term IV nutrition. But this isn't guaranteed and takes a long time. In highly selected cases, particularly younger patients facing lifelong TPN, small bowel transplantation may be considered as a treatment option.
So, acute ischemia is truly catastrophic. What about chronic small intestinal ischemia? That sounds less dramatic, but still serious.
It is less dramatic in onset, but can be very debilitating. Chronic mesenteric ischemia is almost invariably caused by severe diffuse atherosclerosis, hardening and narrowing of the arteries, affecting the origins of the major visceral arteries. Typically, both the proximal SMA and the coeliac artery need to be significantly stenosed or occluded for symptoms to develop because of the collateral networks.
And what's a classic symptom?
The classic symptom which the text highlights is severe, crampy, central abdominal pain that typically starts 30 to 60 minutes after eating. It lasts for an hour or two and then gradually subsides.
And I'm guessing that timing is because eating triggers increased blood flow demand to the gut for digestion and absorption, and the narrowed arteries just can't deliver enough oxygenated blood to meet that demand.
Exactly right. It's the intestinal equivalent of angina pectoris in the heart exertion, eating, causes pain due to insufficient blood supply. It's often called mesenteric angina or intestinal angina.
What other symptoms might occur?
Patients often develop a significant fear of eating because they know it will bring on the pain. This cytophobia leads to reduced food intake and often profound weight loss. Malabsorption due to chronic low blood flow can also contribute to weight loss and sometimes cause diarrhea.
Diagnosis sounds like it could be tricky, maybe mistaken for other things.
It can be, and it's often overlooked, especially in elderly patients who may have multiple other reasons for abdominal pain or weight loss. The text makes an important cautionary point. Just finding significant atherosclerotic disease in the mesenteric vessels on a CT scan in an elderly patient doesn't automatically mean their abdominal symptoms are due to chronic ischemia, as asymptomatic vascular disease is actually quite common in this population. A thorough evaluation is needed. Diagnoses often require specialized imaging like CT angiography or MES-R angiography, or sometimes formal selective visceral angiography, catheter-based, to accurately visualize the narrowed arteries and assess their hemodynamic significance.
How is chronic ischemia treated?
Treatment aims to improve blood flow to the intestines. This can often be achieved with endovascular techniques like inserting stents via catheters to open up the narrowed SMA or coeliac artery, angioplasty and stenting. If stenting isn't possible or fails, surgical bypass grafting, using either a vein graft or a synthetic tube to bring blood flow from the aorta or iliac arteries to the SMA or coeliac artery distal to the blockage, may be necessary. Lifestyle changes, particularly smoking cessation, are absolutely imperative. Patients are also usually placed on antiplatelet agents or anticoagulation to help prevent clots from forming in the narrowed or stented vessels. Okay, let's move now from problems with blood supply to conditions that cause severe functional impairment of the small intestine, often requiring long-term intensive support. The source discusses enterocutaneous fistula and then short bowel syndrome leading to intestinal failure. Right. These are major challenges in gastroenterology and surgery. An enterocutaneous fistula, first, is an abnormal tract or connection that forms between the lumen, the inside of the small intestine, and the skin surface, allowing intestinal contents to leak out onto the abdomen. They are notoriously difficult to manage.
What are the common causes? Why do these form?
The causes listed in the text include underlying diseases like Crohn's disease, which can cause spontaneous fistulation, complications of radiotherapy to the abdomen, or abdominal trauma. However, the most frequent cause, accounting for the majority of cases in developed countries, is actually as a complication following abdominal surgery.
A surgical complication, how?
It can be due to a breakdown or leak from a surgical joint where two pieces of bowel were connected, an anastomotic leak, or it can result from an inadvertent injury to the bowel during the operation itself, an unrecognized or delayed enterotomy, perhaps while dissecting dense adhesions.
And the more abdominal surgery someone has had, the higher the risk of developing one later.
Yes. The text notes that the risk increases significantly with the number of previous laparotomies. This is often due to the increased difficulty of subsequent operations, where inadvertent injury to the intestine while carefully separating extensive adhesions from prior surgeries is more likely.
Managing fluid leaking from the bowel directly onto the skin sounds incredibly difficult and unpleasant.
It is, extremely. It's particularly challenging with high output fistulae, which the text defines as leaking more than 500 milliliters of effluent per day. Low output fistulae, less than 500 millimolar, may sometimes heal spontaneously with conservative management, but only if certain conditions are met.
What conditions favor spontaneous healing?
Spontaneous healing is much more likely if there's no obstruction in the bowel downstream from the fistula, allowing normal flow to bypass the opening, no active disease like Crohn's or radiation damage at the fistula site itself, and no continuous epithelialized tract formed right from the gut lining to the skin surface, which prevents closure. Spontaneous healing often fails if these factors are present or if there's an associated complex abscess cavity connected to the fistula.
So you can't just wait and hope it closes in many cases. There needs to be a structured approach.
Absolutely. And the management approach is systematic and multidisciplinary, often summarized by the mnemonic SNAP, which outlines the key principles.
SNAP. Okay, let's break that down. What does S stand for?
S stands for elimination of sepsis and skin protection. This is the absolute first priority. The text strongly states that attempting definitive corrective surgery in a septic, malnourished patient with an active fistula is doomed to failure. So any collections of pus abscesses or signs of systemic infection must be identified, usually with CT scanning, and aggressively treated, often best done initially with CT-guided percutaneous drainage catheters, as shown in one of the figures.
Okay, control the infection first. And skin protection.
Equally vital from day one. Small bowel effluent is liquid, contains powerful digestive enzymes, and has a high bile salt concentration, making it extremely caustic and damaging to the surrounding skin. It can cause severe excoriation and breakdown very quickly. Effective skin protection using barrier creams, pastes, and specialized stoma appliances or wound management systems to collect the effluent and keep it off the skin is essential for patient comfort and to allow healing.
So, control infection and protect the skin. That's S. What's N?
Yes, N is for nutrition. This is critical. Patients with enterocutaneous fistulae, especially high output or proximal ones higher up in the small bowel, lose massive amounts of fluid, electrolytes, protein, and other nutrients through the fistula effluent. They rapidly become malnourished and dehydrated. A period of parenteral nutrition, again, giving all necessary nutrients intravenously, is often required initially to stabilize the patient, replete losses, and allow the gut to rest somewhat.
Is it always intravenous feeding?
The text discusses the balance. Enteral feeding, using specialized liquid diets delivered via tubes into the stomach or jejunum, if possible, bypassing the fistula, has advantages like maintaining gut mucosal health, but it might increase fistula output. For proximal or high output fistulae, total parenteral nutrition, TPN, is usually necessary, at least initially, to fully support the patient nutritionally and allow precise replacement of ongoing fluid and electrolyte losses, which must be meticulously measured and replaced. Adequate hydration and correcting electrolyte imbalances are absolutely crucial.
Okay, S for sepsis skin, N for nutrition. What's A?
A is for anatomical assessment. Once the patient is stabilized, sepsis is controlled, and nutritional support is established, you need a clear picture of the fistula's anatomy. Where exactly does it originate from in the bowel? What is its path? Is there downstream obstruction? What is the length and condition of the remaining bowel? This anatomical roadmap is essential for planning any definitive treatment.
How do you get that map?
This is best done in close collaboration with a radiologist. It often requires a sequence of different contrast studies. A fistulogram involves injecting contrast directly into the external opening on the skin to trace the tract back to the bowel. A small bowel follow-through, or enteritis, where contrast is drunk or infused, helps visualize the bowel proximal to the fistula and look for other pathology or obstruction. Sometimes a contrast enema is needed to assess the colon. CT scans can also help define associated abscesses or inflammatory masses.
So map the problem thoroughly. SNAP must be the final step.
Yes. P stands for definitive planned surgery. Once the patient is stable, sepsis-free, well-nourished, and the anatomy is clearly defined, planned surgery can be considered to close the fistula. This usually involves resecting the segment of bowel containing the fistula origin and then rejoining the healthy bowel ends, anastomosis. However, this type of surgery is often technically very demanding due to dense inflammation, scarring, and adhesions from previous operations and the fistula itself.
Are there times when surgery should definitely not be done, even if planned?
Yes, the text explicitly lists conditions under which attempting to perform an anastomosis, joining the bowel back together, should generally be avoided because the risk of it failing and leaking again is too high. These include the presence of ongoing, uncontrolled intra-abdominal sepsis or severe malnutrition, as indicated by hypoalbuminemia, low blood albumin levels, typically cited as less than 30 or 32 GDL in the source. These factors indicate a poor physiological state for healing. Surgery is typically deferred until the patient is optimized, stable, sepsis-free, and with adequate nutrition. Sometimes a staged approach is needed, perhaps initially just resecting the fistula and creating temporary stomas with definitive reconstruction later.
So it's a really careful staged process. Stabilize, nourish, map, and only then undertake complex surgery when the conditions are absolutely optimal. It sounds like it requires a very dedicated, multidisciplinary team approach.
Precisely. It involves surgeons, gastroenterologists, radiologists, dietitians, stoma nurses, and intensive care specialists working closely together. Now, related to this, let's discuss short bowel syndrome, SBS, and the broader concept of intestinal failure, IF.
These sound like the ultimate consequences of losing too much small intestine, either through surgery or disease.
They are. Short bowel syndrome is generally defined clinically by the consequences of having insufficient absorptive surface area in the remaining small intestine. This typically manifests as intractable diarrhea, dehydration, electrolyte disturbances, and impaired nutrient absorption following extensive resection or bypass of the small intestine, leading to progressive malnutrition if unsupported.
Okay, that's SBS. What's intestinal failure? Is it the same thing?
Intestinal failure, IF, is a broader functional definition. It's defined as the reduction of gut function below the minimum necessary for the absorption of macronutrients and/or water and electrolytes, such that intravenous supplementation is required to maintain health and/or growth. So, IF is the state where you rely on IVs for hydration and/or nutrition because the gut can't do its job adequately. SBS is the most common cause of IF in adults.
So intestinal failure means you rely on IVs for basic hydration and nutrition. What are the most common reasons people end up with SBS leading to IF?
The text states that extensive surgical resection for Crohn's disease and its complications is the most frequent cause in adults, accounting for nearly half of all cases in some series. Other major causes include massive resection required for mesenteric vascular thrombosis, acute mesenteric ischemia, complications of radiation enteritis damaging the bowel, certain abdominal tumors requiring large resections, and conditions like complex abdominal trauma.
Is there a specific minimum length of small bowel you need to have left to avoid developing SBS?
Features of SBS usually start to appear when less than 200 centimeters of functional small bowel remains after resection. The normal length is highly variable, remember, but can be 600 centimeters or more. However, the absolute length alone isn't the sole determinant. The nature and location of the remaining intestine are critically important too.
What do you mean by the nature and location?
Well, diseases that cause SBS, like Crohn's or ischemia, often preferentially affect the distal small bowel, meaning the ileum is lost. As we discussed earlier, the ileum has unique absorptive functions, B12, bile salts, and is particularly good at absorbing water and salt due to its tighter cellular junctions compared to the jejunum.
Right, the ileum has special jobs the jejunum can't do.
Exactly. The ileum has a remarkable ability to adapt and increase its absorption of things normally handled by the jejunum if the jejunum is resected. But the jejunum cannot take over the terminal ileum's unique absorption of bile salts and vitamin B12. The text also notes that while the ileocecal valve, the valve between the ileum and colon, was traditionally thought to be crucial for preventing rapid emptying and bacterial reflux, its importance may actually reflect the benefit of preserving the adjacent distal ileum and, critically, the right colon, rather than the valve itself being the key factor.
So having your colon intact makes a big difference.
Huge difference. The colon is extremely efficient at absorbing large volumes of water and electrolytes. It can also salvage a modest amount of energy by fermenting unabsorbed carbohydrates that reach it into short-chain fatty acids, which can then be absorbed. Patients who have had massive small bowel resection but still have their entire colon connected, a jejunal colic anastomosis, are much better able to tolerate the fluid losses and maintain hydration than patients whose remaining small bowel ends in a stoma, like a jejunostomy or ileostomy.
That makes sense. Does the text give any specific length thresholds linked to outcome, particularly regarding the need for 5e support, depending on whether the colon is present?
Yes, it provides some useful general guidelines. Assuming an intact colon is present, patients with around 200 centimeters of remaining jejunum connected to an intact colon may be able to maintain their macronutrient status and fluid electrolyte balance with careful oral intake and medications, though they'll still be at high risk of fat-soluble vitamin and B12 deficiencies and will usually need oral supplements. With 100 centimeters of small intestine remaining connected to an intact colon, some patients will manage, but many will develop intestinal failure requiring some IV support. And almost all patients with 50 centimeters or less of jejunum connected to an intact colon will have definite intestinal failure requiring long-term IV nutrition and fluids.
And what if they don't have an intact colon? If their remaining small bowel ends in a stoma?
Then the threshold length needed to maintain independence from IV support is much higher. The text suggests that most patients with less than 200 centimeters of small intestine ending in a stoma will have IF. And virtually all patients with less than 100 centimeters of small intestine ending in a stoma will require long-term parenteral nutrition to survive, mainly because of the massive fluid and electrolyte losses. This really underscores just how important the colon's contribution to fluid absorption is when small bowel length is compromised.
How is SBS managed medically, apart from IV support if needed? What do you do for the symptoms?
Management focuses on controlling the symptoms, primarily the severe diarrhea, and replacing nutritional and electrolyte deficiencies. Antidiarrheal medications like loperamide, often in high doses, and codeine phosphate are used to slow down the rapid intestinal transit. If bile salt malabsorption is contributing significantly to diarrhea after ileal resection, medications like cholestyramine that bind bile salts can sometimes help, although they can also worsen fat malabsorption. Proton pump inhibitors, PPIs, are often used to reduce gastric acid secretion. Gastric acid hypersecretion is common after extensive small bowel resection, possibly due to loss of inhibitory hormones normally produced by the distal gut. The small bowel brake on acid production is lost. Reducing acid can decrease the volume fluid entering the remaining bowel. Patients require meticulous monitoring and supplementation of vitamins, especially fat-soluble A, D, E, K, and B12, and trace elements like zinc and magnesium, often needing intravenous replacement.
What about newer therapies? Anything to help the bowel adapt better?
The text mentions there's ongoing interest in research into agents that might promote intestinal adaptation, encouraging the remaining bowel lining to grow and increase its absorptive capacity. Examples include growth hormone, the amino acid glutamine, and newer agents like GLP-2 analogs, for example, teduglutide. However, it notes that while some show promise, their established role in routinely managing established SBS in adults was still being fully defined at the time the source was written.
So, if medical management and dietary changes aren't enough, what is the cornerstone of treatment for severe intestinal failure?
The mainstay of treatment for patients with irreversible intestinal failure is home parenteral nutrition, HPN. This allows patients to receive their full fluid, electrolyte, and nutritional requirements intravenously, usually via a long-term central venous catheter, in their own homes, often infused overnight while they sleep.
That sounds life-changing.
The development of HPN, really pioneered in the late 1960s and 1970s, was a true revolution. It transformed the prognosis for patients with catastrophic gut loss who would otherwise inevitably have starved or died from dehydration. Most patients on HPN today can lead relatively active lives with a reasonably good quality of life, although it requires significant commitment. Long-term survival on HPN is now primarily determined by the patient's underlying disease that led to the intestinal failure rather than the IF itself.
But HPN must come with its own set of challenges and risks, right? It sounds complex.
It is both complex and carries significant risks. It's expensive and demands a huge amount of training, time, and meticulous care from the patient or their caregivers to manage the infusions and care for the central line. The major risks are associated with that indwelling central venous catheter needed for access. These include catheter-related bloodstream infections, sepsis, which can be life-threatening, and catheter blockage or thrombosis clotting.
What about long-term metabolic problems from getting all nutrition intravenously?
Yes, long-term metabolic complications can also occur over years of HPN. These can include parenteral nutrition-associated liver disease, PNLD, which can range from fatty liver to fibrosis or even cirrhosis in severe cases, gallstones due to lack of normal gut stimulation of the gallbladder, metabolic bone disease like osteoporosis or osteomalacia, and kidney stones. Careful monitoring and formulation adjustments are needed to minimize these risks.
Are there any surgical options to try and help the remaining bowel adapt or function better?
The text mentions that various surgical procedures have been developed, attempting to improve intestinal function in SBS. These aim either to increase the effective mucosal surface area, like splitting and lengthening the Bianchi procedure, or to slow down the rapid intestinal transit, for example, creating artificial valves or reversed bowel segments. It notes these procedures have shown some promise, particularly in children with SBS, but their benefit in adults with established SBS isn't as clearly established according to this source. They are complex operations.
When is small bowel transplantation considered? That sounds like a last resort.
It generally is considered for patients with irreversible intestinal failure who are dependent on HPN but are developing severe life-threatening complications from the HPN itself. The main indications mentioned are the imminent loss of all suitable central venous access sites due to repeated infections or clots, or the development of progressive end-stage liver dysfunction related to the PN that isn't reversible.
How successful is transplantation?
The text notes that outcomes for small bowel transplantation, which can be done as an isolated small bowel transplant, or combined with liver, or even multiple abdominal organs, have significantly improved over the years thanks to advances in surgical techniques, immunosuppression, and post-transplant care. It mentions that 5-year patient survival rates now exceed 80% in some experienced centers. However, it remains a highly complex procedure with significant risks, primarily related to rejection and infection due to the heavy immunosuppression required. The source refers to another chapter for more details.
That's a hopeful development in what is clearly a very challenging clinical scenario. It truly shows how absolutely vital the small intestine's function is day to day and the incredible lengths required to support life when that function is lost.
It really does highlight the critical balance and also the resilience, but sometimes the extreme vulnerability of this intricate system.
Definitely. Let's wrap up our deep dive today by discussing a common surgical intervention that's often required when the small intestine is diseased, needs to be rested, or has functionally failed: the creation of stomas.
Right. A stoma is essentially an artificial opening created surgically. The wall of the bowel, either small intestine or colon, is brought out through the abdominal wall to the skin surface. This diverts the feces and/or flatus outside the body, where they are collected in an external appliance or bag worn by the patient.
Why are stomas created? Are they always permanent?
They can be created for various reasons and can be either temporary or permanent, as summarized in one of the boxes in the text. Temporary stomas are often created upstream from a surgical joint, anastomosis, further down in the bowel, to divert the fecal stream and allow that joint to heal safely without being stressed by passing stool. Or they might be created in emergencies like perforation with severe contamination, with the plan to reverse them later. Permanent stomas are necessary when the downstream bowel, including the anus, has been removed, like after removing the entire rectum and anus for cancer or IBD, or is permanently non-functional.
And the main types are colostomy from the colon and ileostomy from the ileum.
Correct. That's the primary distinction based on which part of the bowel is brought out. A colostomy is fashioned from the colon, and an ileostomy from the ileum, usually the terminal ileum, the final segment of the small intestine. Stomas can also be created as loop stomas, where a loop of bowel is brought out with 2 openings visible, one functional, one not, which are typically temporary or used to defunction, divert flow away from a segment of bowel further down. Or they can be created as end stomas, where the cut end of the bowel is brought out as a single opening. End stomas are often permanent, but can be temporary too.
What's a key visible difference between an ileostomy and a colostomy that you might notice?
A crucial practical difference in how they are constructed, which is usually visible, is that an ileostomy is typically constructed with a spout. This means the end of the ileum is averted, kind of turned inside out like a cuff, and sewn to the skin so it projects out maybe 2 to 4 centimeters from the skin surface. A colostomy, conversely, is usually fashioned flush with the skin surface.
And why the spout for an ileostomy? Why does it stick out?
That's directly related to the nature of the effluent, the output, from the ileum. Ileostomy output is typically liquid or semi-liquid, continuous throughout the day, and contains active digestive enzymes and bile salts. This makes it highly irritating and potentially damaging to the skin if it sits in contact with it. The spout helps to direct this caustic output away from the surrounding skin and directly into the collection bag.
Ah, okay. And colostomy output.
Colostomy output, especially from the left side of the colon, is typically much more solid, similar to normal stool, and passed less frequently. Because it's less liquid and much less enzymatically active, it's far less irritating to the skin, so a flush stoma is usually adequate and easier to manage with an appliance.
So the nature of the output dictates the construction and also likely impacts patient care and potential problems.
Absolutely. Patients with ileostomies, because they're losing fluid and electrolytes continuously from the small bowel without the benefit of the colon's absorptive function, are significantly more prone to developing dehydration and electrolyte imbalances, particularly sodium depletion. This requires careful attention to fluid intake and sometimes medication. Ileostomies are typically sited in the right iliac fossa, lower right abdomen, while colostomies are usually sited in the left iliac fossa.
And getting specialist stomach care nursing involved sounds essential.
Critically important. The text emphasizes the absolutely vital role of the specialist stomach care nurse. It strongly recommends preoperative counseling, education, and importantly, careful preoperative stoma siting by the nurse whenever possible in elected cases. Proper siting, taking into account skin folds, scars, the patient's belt line, and visibility for the patient, is crucial for ensuring a good appliance seal, preventing leaks, and making self-care easier for the patient long term. The source mentions the surgeon Brian Brook in relation to popularizing the spouting technique for ileostomies to minimize skin problems.
Let's look at the types in a bit more detail. What is a loop ileostomy typically used for?
A loop ileostomy is very commonly used temporarily to divert the fecal stream away from a surgical joint, anastomosis, lower down in the bowel that needs protection while it heals. Classic examples are after creating a low rectal anastomosis following rectal cancer surgery, or after constructing an ileal pouch, J-pouch, for ulcerative colitis. Diverting the stool allows the joint to heal without the stress and bacterial load of feces passing over it.
How is a loop ileostomy actually created?
Usually, a loop of ileum, typically quite close to the terminal end, is brought out through a small circular opening made in the abdominal wall, usually in the right iliac fossa. An incision is then made across part of the circumference of the distal limb of this exteriorized loop, the limb leading towards the colon. This distal end is then often pulled over the proximal functioning limb to help create the spout on the proximal side, while the distal non-functioning opening remains connected but usually lies flush or slightly retracted. This provides near-perfect diversion of the fecal stream away from the downstream bowel.
Is it easier to reverse later than other types of stomas?
The potential for later closure and restoration of intestinal continuity is a major advantage, and the primary reason for creating loop ileostomies. Reversal involves mobilizing the stoma from the skin, trimming the edges, and then rejoining the partially divided bowel, usually with sutures or staples. However, even closure requires careful surgical technique to avoid creating a narrowing stricture at the suture line. And the procedure itself can sometimes be technically challenging due to adhesions that form around the stoma site from the initial surgery. An advantage over a loop colostomy is often the ease of bringing the more mobile ileum to the surface without tension.
What about an end ileostomy? When is that formed?
An end ileostomy is formed when the cut end of the ileum is brought out as the stoma opening. This is necessary after removal of the entire colon, total colectomy, without an immediate plan for reconnection, in which case it might potentially be reversed later if the rectum is preserved. Or it's formed after removal of the entire colon and rectum, panproctocolectomy, usually for conditions like ulcerative colitis or FAP, in which case the end ileostomy is typically permanent.
How is the end ileostomy made?
The cut end of the terminal ileum is usually brought out through the rectus abdominis muscle, one of the main six-pack muscles, rather than beside it, to try and reduce the risk of peristomal hernia formation. Care needs to be taken when bringing it through the abdominal wall, as the mesentery of the terminal ileum can be bulky. The Brook technique is then used to avert the end of the ileum and suture it to the skin, fashioning a spout that projects typically 2 to 4 centimeters from the skin surface. A disposable adhesive stoma bag appliance is then fitted snugly around the base of the stoma to collect the output. Figures in the source illustrate the construction and the appearance.
What's the typical output volume from an end ileostomy? Does it change over time?
Initially, especially in the first few days or weeks after surgery, the output can be very high and watery, phenomenon sometimes called ileostomy flux, as the remaining ileum hasn't yet adapted to its new role of absorbing more fluid and electrolytes. Output can occasionally reach 4 or 5 liters per day in this early phase, though 1-2 liters is perhaps more common later. However, the text makes the important point that a consistent output exceeding 1.5 liters per day usually indicates the patient is becoming significantly dehydrated and sodium depleted unless they are managing their intake and losses very carefully or receiving supplementary 5E fluids.
That's a real risk. Does the output consistency change?
Yes. Thankfully, the remaining ileum usually does adapt significantly over time. The output gradually thickens over weeks and months, eventually becoming more semi-solid or paste-like after several months as the ileum increases its water and salt absorption. Expert advice and support from a stoma care nurse are invaluable during this adaptation phase for managing output, taking appliance changes, dietary adjustments, and recognizing potential problems like dehydration. Modern stoma appliances are very effective and skin-friendly, so severe skin problems around the stoma are now much less common than they were historically, provided the stoma is well-formed and the appliance fits correctly.
What are the potential complications that can occur with having a stoma, either ileostomy or colostomy?
The source lists a range of potential complications, highlighting that their frequency is often underestimated. They're actually quite common. These include problems directly related to the stoma itself: skin irritation or breakdown, peristomal dermatitis; prolapse, where the bowel protrudes excessively through the opening; retraction, where the stoma pulls back below skin level, making appliance fitting difficult; ischaemia, lack of blood supply causing tissue death, usually an early complication; stenosis, narrowing of the stoma opening, obstructing output; bleeding from the stoma surface, or fistula formation adjacent to the stoma.
And some of these might require further surgery to correct.
Many of them might, yes. Surgical revision can sometimes be a relatively minor local procedure performed around the stoma itself, or it might sometimes require reopening the main abdominal incision, laparotomy, to refashion or relocate the stoma completely. The text specifically notes that the repair of peristomal hernias, which are incisional hernias occurring right beside the stoma site as the bowel pushes through the abdominal wall defect, is particularly technically challenging, and the recurrence rate after repair is notoriously high.
So a simple suture repair of a peristomal hernia isn't usually effective long term.
The text states quite starkly that simple suture repair of a peristomal hernia has an almost 100% recurrence rate, which is quite striking, because the underlying issue is often tissue weakness around the opening created for the stoma. Simply stitching it closed usually fails. More complex strategies are often required, such as relocating the stoma to a completely different site on the opposite side of the abdomen, or, more commonly now, using prosthetic mesh material placed within the abdominal wall layers around the stoma during the repair to reinforce the area and prevent recurrence. The text refers to a chapter specifically on hernias for more detail on these techniques.
Wow. So while stomas are clearly life-saving or significantly life-improving interventions for many people, they definitely come with their own distinct set of potential early and late complications that require specialized surgical expertise and ongoing, often lifelong, expert nursing care and patient vigilance.
Absolutely. They represent a significant physical and psychological change in a patient's life that necessitates considerable adaptation and continuous support from the healthcare team.
We have taken a truly deep dive into the small intestine today, haven't we? Using this source material, we've explored its fascinating, intricate anatomy and its absolutely vital physiological roles. We've covered the wide range of conditions that can affect it, from common infections and inflammatory diseases like Crohn's to rare but significant tumors, devastating vascular events like ischemia, the consequences like malabsorption and short bowel syndrome leading to intestinal failure, and finally, the crucial role of surgical interventions like resection and the creation of stomas.
Exploring the text in this level of detail really allows you to see those connections: how structure dictates function, how disruption of that structure or function leads to specific pathologies, and the sheer complexity involved in diagnosis and management across all these different conditions. We've aimed to cover the foundational knowledge and the clinical context presented, drawing out the key points, just like duodenals in the field would need to grasp.
Yeah, and thinking about it, we've seen the small intestine's remarkable capacity for adaptation in some circumstances, like the ileum potentially compensating after jejunal loss, or young patients adapting after massive resection, contrasted starkly with its extreme vulnerability in others, like the incredibly rapid, irreversible damage caused by acute ischemia.
Indeed, it's that contrast that's so striking. And perhaps a final thought to leave you with, drawing from everything we've discussed, thinking about the sheer volume of fluid the ileum handles and adapts to absorb daily, especially after colon removal, or how just a tiny misplaced patch of stomach lining in a Meckel's diverticulum can trigger such a cascade of serious complications. It really underscores just how incredibly complex and yet how delicately balanced this whole system truly is, doesn't it?
It absolutely does. A very powerful system, but one where small disruptions can have huge consequences. And that's a great thought to ponder as we wrap up this deep dive. Thanks for joining us.